welcome to our panel discussion on telehealth for the Rise West Conference. We're really excited to talk to everyone here. And my name is Mark Bigelow. I'm the Vice President of Risk Adjustment and Quality for EXL Service, and very excited to talk with this fantastic panel who's got a lot of experience in telehealth. So I'm going to turn it over to each of them to introduce themselves and give you an idea of what their background is, and then we can dig in from there. So first, I'll start with Mark Ishimatsu.
Thank you. My name is Mark Ishimatsu. I'm Director of Enterprise Risk Adjustment for LA Care. We oversee both the Medicare and also for commercial products in risk adjustment.
Thanks, Mark. Great to have you. Laura, do you want to introduce yourself?
Yes. Hi, I am Laura Sheriff. I am currently working as a consultant as a risk adjustment specialist. My background includes the provider and the payer side of things. With my most recent job was with Molina Healthcare as the National Director of Risk Adjustment.
Fantastic. Thank you. Andy, over to you.
Great. Hey, everyone. I'm Andy Elner. I am founder and Chief Clinical Officer of Firefly Health, which is a advanced virtual first primary care offering that now is building a full benefit for employers. Prior to that, I spent a decade on the faculty at Harvard Medical School, where I was founding co-director of the Harvard Medical School Center for Primary Care.
Wonderful. I'd like to thank each of you for joining us. We're going to have a great discussion here, and especially it's a great time to have this discussion as we're starting to see some lockdowns happen again, or at least mask mandates, and potentially some issues around in-person care happening again. So would like to get each of your thoughts, first of all, on some notable wins that you've seen in telehealth in your experience. And then we can kind of go from there into some hiccups that you've seen as well. Laura, do you want to start? What are some of the things that you've seen work really well in implementing telehealth for risk adjustment?
One of the biggest things that I've seen is we have to work together with other departments within the organizations. So we have to be able to target the right interventions with the right people at the right time. And so I think being thrown into telehealth like we were last year, it's created a better symbiotic relationship between quality and case management. So that's one huge win, I think, for working for something positive around telehealth.
Oh, fantastic answer. Thank you. Mark, what about you?
Yeah, I think for us, one of the biggest things we've seen has been really the kind of the adoption of telehealth and kind of the comfort level with that, both on the provider side, obviously on the patient side. And also interesting is the plans seem to be trying to serve as a conduit for this, and you know, that as well as caused some issues and some problems, I think, in coordination of that. But likewise with Laura, I think also is, as we were looking for solutions, all our other departments were looking for solutions as well within the plan, and the conversation quickly bloomed into kind of an enterprise level discussion around, you know, should we be promoting certain kinds of technology? You know, what's our role as a payer inside this, or do we just let the providers kind of fend for themselves and figure it out? But that discussion went on, and I think it really helped to drive some direction for us about how we're going to approach this moving forward.
Absolutely. Yeah, thank you. So Andy, I want to kick it over to you. You come from a different perspective, though, right? As a vendor helping lots of plans implement these telehealth things, you've seen a lot of these things happen that Mark and Laura talked about. So what are some of the biggest wins you've seen for your clients?
Yeah, thanks, Mark. I'm glad to acknowledge that I'm a bit of an ugly duckling on this panel, but really enjoy being a part of the discussion.
No ugly ducklings.
So, you know, we've been doing virtual first, sort of an aggressively virtual model of care now for about 3.5 years. And just a lot of wins around. The way I'd say it is the approach we've taken at Firefly, my company, is not to say, hey, we have this sick care system that already doesn't work that well. Now we're going to do video visits in that broken way of delivering care. We really try to step away from that and say, what's the best care for this given person or this population, and not be tied to, for example, visits that often aren't necessary when what we're trying to do is help someone with a chronic condition or ensure they're getting preventive care. And so, we've just found that we can actually deliver a model of care that's superior from a quality and safety perspective by using technology to enable more of a continuous connection and a proactive approach to helping people achieve their health goals and kind of figuring out what's going on when they're sick and following up on things. So we have a lot of data at this point that, chronic condition outcomes are about 20 points higher than, the average for the populations we're taking care of. And, you see improvements in utilization, reduction in unnecessary emergency room visits. We see about a 50% on pre-post analysis when you're offering, more of a continuous connection rather than a sort of episodic sick care model. Where there are hiccups is where the payment is kind of inflexibly structured towards the more traditional sick care visit-based approach, where it's sort of strictly fee-for-service, and the fee-for-service is tied to having to do a visit when often you could take care of something over chat or some other means of delivering the service that might be asynchronous rather than synchronous, for example. So I think that's where we still kind of run into hiccups when we're working with payers.
Really interesting. So it sounds like what each of you are describing is that telehealth has sort of brought on this transformational shift in the way we're delivering care and thinking about care. I think it's definitely true. In any best scenario, a transformational change like that can be disruptive and have a lot of issues. Like you're saying, I think that the telehealth part has outpaced sort of our transition to BBC, and so there's a disconnect there. I'd be interested in hearing, Laura, from you maybe, what are some of the other hiccups that you've seen in trying to sort of make a transformational shift on the fly in a really short amount of time?
Well, I think it would be a lot of things that we were very unfamiliar with telehealth for Medicare and Medicaid. And so it was having to figure out pretty quickly that some of those people had no idea of the technology that was needed in order to even participate in telehealth, and how frustrating that was for that population. A personal experience for me is that both of my parents one's in the late 70s and one's in the early 80s. And just working with them to figure out how to even make the technology happen was super frustrating for them. And I can't imagine that, on a more global scale. And so obviously, we ran into trouble pretty quickly because we could not really reach our Medicare population. And I think that was obviously across the board. So that was one giant hiccup for us that we had to think about. We had to think outside the box on how we were going to help those members keep up with their care.
Can you tell us more about how you kind of solved that problem and reached out to those members?
So one of the big things that we did was we looked at our larger provider groups that had obviously the larger member populations, and we actually outreached to those provider groups and asked them, hey, do you need help? And it was very interesting. Usually in the past, I think it's really hard sometimes to get your foot in a provider office. However, the provider offices were also short on staff, especially if COVID was, running in their area. And so we would give them a targeted list of members, and they would get back with us and say, these are the members that we're really having trouble with. Can you help us? And so we would call those members and schedule a telehealth visit with those providers. The other thing that we did to help on the provider side of things was to kind of create like a telehealth cheat sheet for the providers, reminding them how they needed to bill for the service, making sure that they were noting in their note that it was a telehealth visit, with audio and visual. So those kinds of things. And we just kind of built some partnerships with some provider groups that we had never worked with before.
Fantastic. Yeah, it's great when you can use something like this to build a better relationship and make improvements. That's wonderful. Now, Mark, on your end, did you have similar issues with members and technology, and how are you able to solve those?
Yeah, we did. I mean, similarly, right now it's a population that's just not that comfortable with a lot of the newer technologies that are involving any kind of video engagement. We did, however, engage our in-home assessment vendor, who also had a pretty sophisticated video protocol about how to set this up. They did a lot of visits and pre-meetings with the patient before their appointment in order to kind of work through some of these technology issues. I think we still saw, obviously, a drop in the number of engagements that we had, the percentage of of the take rate in terms of the video visits, but it was still higher than I had kind of expected when this all started. So the technology one solutions is trying to solve that issue is something I think the industry really needs to think about. I think there's a lot of different opportunities here, but it's access to the technology, it's the comfort with the technology, and the actual engagement with it, as well as on the provider side, them also being comfortable with the technology. And I think some of the issues we saw were, as we begin to look back now at some of the visits and early visits that were done by our providers with the video calls, we noticed there was a drop in kind of what they were capturing in the engagement, it was lower than what our vendor was doing, which gave us some indication around kind of the comfort and expertise and experience in actual medical engagements with this technology. It's different. I think it's slightly different skill set, and I think it's something we need to think about addressing moving forward.
That's a great point, because I believe all these conditions are risk adjustable over a telehealth visit. But you're saying that some of your providers weren't comfortable coding those over telehealth. So what kind of training, education did you do with your providers to get them more comfortable with that?
Well, we haven't provided kind of a formal training. What we did is we're just relying more heavily on really the vendors who are specialized more in telehealth business, particularly on video side. And there's a number of things that are done. One is, I think, the providers, because if that's kind of what they do and all they do, then it is a process or procedure around which they're comfortable with. They know how to engage these things. They know how to engage the member in order to kind of ferret out some of these diagnoses that need to be identified and subsequently coded. And I think that's that's where we kind of pushed it on, and we have not kind of engaged or set up any kind of training, like we do with coding. We haven't set up any kind of training associated with kind of the video visits. I think that's an opportunity for us. I think it's an opportunity in the industry, because I think there's a real difference. There's a market qualitative difference in how that engagement takes place and how it should take place, and it's a skill that needs to be learned.
Interesting. Andy, I see you nodding over there. Your entire business is hiring providers and training them to do these visits correctly. So what are some of the things you have to train the providers differently on a telehealth visit that they might not be used to?
Yeah, that's an interesting question. There's I'd say a couple quick things specifically regarding your question of the visit. There's things that you don't think about, like lighting and having a professional background, and ensuring that there's not a lot of noise and things like that you just don't tend to think about otherwise. And there's some gadgets that you can use to increase the quality of the video visit. We're actually, right now, what we do is we have patients rate their experience after each visit, and we also, the providers rate the quality of the video interaction, so that we can both optimize the technology side of the video visit experience, and we can ensure that our providers are providing, great service, great care. They're still really connecting when they deliver care virtually, and the feedback is usually, great. People really love it when they can kind of have that same high quality interaction and connection with the provider, but without leaving, their home or their office. I will sort of hammer over and over again, probably today, the point that telehealth is not video. Video visits is from my perspective, a pretty narrow part of what we ought to be aiming for in a technology-enabled approach, or more kind of remote approach to care, because so much of the barriers that our patients face are around adhering to medications, changing their behaviors, just things that you just can't accomplish in a video visit. But if you have a sophisticated way of connecting with people over time, supporting them longitudinally, and we have, teams of providers that include health coaches and behavioral health specialists that can take care of the whole person. You can do something much more sophisticated than a sort of traditional visit-based or sick care model.
Yeah, that's really interesting, because I think whenever the pandemic hit last year, I kind of viewed telehealth as sort of a stopgap measure to be able to get, our HCCs to be more accurate while we have this lockdown. And it's interesting that what you're positing is actually a fundamental change in the way that we think about telehealth visits. It's not just a one-time visit. It's just, this ideal model of care we have around wrapping around the member and engaging them in their care can be done via telehealth as well, not just in person. I think that's really, really interesting, and potentially could help engage members that otherwise wouldn't be. So Laura, I wanted to turn it over to you, because you made an interesting point that you have to target the right member for a telehealth visit. And so I wanted to get some more thoughts from you on that. What type of member do you think is ideal for a telehealth visit, especially considering what Andy just said? Some of these members that might not engage otherwise can be engaged into a more comprehensive type of care through telehealth.
So two very specific examples of that would be targeting members who are just coming out of the hospital, and doing telehealth follow-up visits with them to keep them out of the hospital. That's always been a struggle, I think, at any health plan is, the statistics, especially for the older population, they end up back in the hospital, and sometimes it's because they didn't have, they just couldn't get out of the house, they didn't have access, they didn't make it to their follow-up appointment. So strategically, you could target members, bring in your care management team and say, hey, these are the members that we need to do telehealth visits on, for this week. And then the other specific example, and I've been reading more and more about this, is the behavioral health community. So if you think about it, a lot of those behavioral health diagnoses, they are already uncomfortable being out of their house. And a lot of them are not really good with, making sure that they follow up with their psychiatrist. I think telehealth brings a whole new level of how to care for the behavioral health member. And because they can just schedule it, it's in their home, it's a comfortable place for them. And I think that it's really going to make a change if we can embrace that and start, moving in that direction and do some big pilots on how we can keep behavioral health members engaged.
Yeah, that's fantastic, because that's long been an issue with traditional care, is diagnosing some of these behavioral health issues. And if telehealth can help solve that, that's wonderful. Mark, similar thoughts from your end? What have you noticed?
Yeah, I think the particular kind of application, our targeting efforts were widened. I think during the pandemic, just because we had a drop in general encounters. but normally we use right now our in-home assessments and our video visits really a much more targeted population. Again, we're trying to close some specific gaps and try around risk adjustment specifically in terms of the application of video visits and in-home assessments. But I also think there's an interesting component, which is whether or not the members and the patients, are even first of all comfortable, and whether we should be reaching out to them with a video visit or not. And I think this also it opened up a whole new area around how we need to kind of collect more information about our member profiles, and it changed the types of data that we're collecting, particularly around consumption of media and the comfort level of video visits, or do they want a voice visit, do they want in-person visit, and it's really changed in terms of kind of that demographic profiles and the elements that we think we need to collect now moving forward. So it's a big change. That was a big change.
That's really interesting. So is that something you're tracking now on your membership? Is there sort of preferred modality?
Yeah, it's something we've been pursuing the last couple of years, just in terms of general engagement with our members. I think the pandemic kind of really elevated that as we started losing obviously in-person visits and encounters, and the question then became really should be reaching out directly for trying to engage in video visits, and from a patient standpoint, care standpoint, we should be attempting that, I think, no matter what. But I think from a cost standpoint and from kind of being able to target this, and we're trying to be smarter about who we should effectively reach out to, because we don't want to kind of badger our members with trying to get them on a video visit. It's really their preference is that they don't want that, and we just don't want to kind of cause that friction. So we're looking at collecting the data that around the demographic profiles that allow us to be smarter around how we reach out to these members and kind of what technologies and modalities we should can be using.
Yeah. Have you noticed an uptick in other modalities beyond telehealth due to sort of the pandemic? So things like mobile visits, things like that?
Well, we did notice that there was, from an encounter standpoint, we did notice that there was a lot of engagement with kind of urgent care in other settings, right? So instead of kind of directly with the provider, because a lot of that was restricted, and we didn't have the offices either closed, or they had very limited number of appointments that were going to be available at any given time. So we did see this just kind of a general diversion around kind of where people were kind of out to engage in care. Kind of just it drove them to kind of another path. I think that was a concern for us, because then we begin to kind of lose and disengage kind of with the care that's going on with the member relative to what the care management may be doing with their PCP. So that issue around kind of how they were seeking care was an issue, and that diversion and kind of outside their normal sphere of care and kind of information that was collected was a little bit concerning, I think, in how those. I think overall, though, I think that our engagement with these members to make sure that information, try to make sure that we can recapture the information and get it back to the provider. But boy, it was kind of quickly kind of went outside our systems, and until by the time we noticed it was kind of an interesting effort to try to figure out, is like, can we really get back and collect all that information and get it back to their PCPs?
Got it. And that's something I also wanted to cover, is looping back with the PCP when these visits are done by a provider other than their PCP. Laura, I think you worked pretty hard on this during the pandemic. How were you able to sort of close that gap and get the provider engaged?
Well, the vendor, we had an internal vendor that did our telehealth, most of our telehealth visits. and the requirement was they had to send the visit over to the provider office after they saw the member. I think that is still an area in healthcare that needs to be sort of figured out, because I think what happens sometimes is that information gets sent and it ends up in this black hole that doesn't end up, where it needs to be. And then, you also have providers that are not happy that you're seeing their members. And so there's that point that you have to address with these providers, because it all goes back to the provider. And I always try to remember the fact that without providers, we have nothing. So I really tried to work with providers that had a negative connotation about the telehealth visit and us seeing their members. But there's always those few that are just not gonna, they just don't want it. So I think we still need to remember those physician relationships. And if they really are against it, then we need to put the onus on them and say, you need to see your members, right? We're just trying to help you out. So, yeah, I mean, that's
exactly right.
Yeah.
Interesting. Yeah. And so maybe there's the opportunity to provide sort of a platform for the providers to engage via telehealth, if that's not an option they already have. So, Andy, I wanted to ask you, I think as part of your process, you probably work to engage providers, or at least keep them aware of what's been happening with the people you're seeing. How has that gone? Have you seen providers be receptive, not receptive? What's been your experience?
Yeah, we're a little different than other sort of telehealth vendors because we replace their primary care. We're not kind of an add-on to primary care, but I will say that there's a lot of constraints and sort of lost opportunities around information sharing. We experience a lot of the same challenges when we refer someone to a specialist, or because we're fully virtual, we partner with urgent care facilities or home services when someone needs something in person. And there's just a lot of constraints and missed opportunities around sharing data in a way that you might expect wouldn't be hard to do in 2021. We're still faxing back and forth and calling specialist offices over and over again just to try to get a note back when they've seen one of our patients. So it's not ideal.
Right. Absolutely. That's good input. So let's move on to, I wanted to move to sort of the operational area and how we implement a program like this. And we've talked about some of the challenges there, I think, but I guess Mark or Laura, what are your thoughts on the best way to go about this from a long-term perspective? Now that this is probably going to become just part of the way we do business, is it best to build a capability like this in-house, to partner with a vendor, to leverage PCPs more? Like, what's a combination of the three? Like, what's our preferred approach here? What do y'all think?
Yeah, for us, I think it's really around engaging on the vendor side, third-party vendor. I think to kind of fill that gap. A couple of reasons why there are. I think particularly on telehealth, I think there is a benefit to having providers and that are engaging the members, even if it's not their PCP. But engaging the providers that is kind of experienced with telehealth. I think that experience around how they engage, the technology, and kind of supporting that system, both from an analytics and kind of pre-visit capability, as well as obviously the actual technology during the encounter itself. I think so. So for us, it's there. Now, doing so, making that completely visible and transparent to our contracted provider network, right? So they understand that this is a method that we kind of reserve the right to pursue for particular needs. Now, for us, in a capitated contract world, not that big of a deal because it's not a lost visit from a case of revenue. It is kind of a loss in terms of engagement with the member and that kind of continuity of care. That part it also needs to be pay a lot of attention to when you think about if you're going to engage a third party, is around how's that the assurance of that information getting back to the PCPs. I think that's critical. We had problems with normally, unfortunately, a lot of this information. I mean, we're probably one of the few industries that still relies on fax machines, like, heavily. And during the pandemic, we had some empty offices and faxes were either piling up or they just weren't getting printed because they ran out of paper. And then, they try to restart their fax machine. We don't know if it kind of made it to the endpoint, so that for the engagement and encounter actually made it into their medical chart. So I think that's something we just have to think about to make sure we close that loop, to make sure that there's not only the record of care is within the medical chart for that member, but it's also then noted and visible to their PCP.
Right. Interesting. Laura, what about you?
I definitely think at least for the larger organizations, you're going to be using every option that you have available to you. So partnering with the physicians is a big one. One of the things that we did too was to help the providers. We would look at their telehealth platform and make sure that it was a compliant, platform. So that's one thing. If you are going to work with providers, you do need to make sure that they understand the whole thing about telehealth and how it should be documented and how to bill for it and all that. As far as using a vendor, we actually had an internal vendor, and then we also brought in an external vendor. So I think when you're looking at the vendor space, one, you also need to identify what population are you going to focus on for that vendor? Is it going to be all of your populations? For us, it actually ended up being mostly marketplace. As you know, marketplace members are working members generally. They're technologically savvy. Telehealth is a perfect platform for them, right? Because they can see a provider, in 30 minutes and never have to leave the office and use it as their lunch break. The other way that you could use a vendor too is to pre-screen your members. So when you get all those marketplace members and you don't have any health history on them, you can pre-screen them with HRAs. And then if they have a chronic condition that needs to be addressed via a telehealth visit, then you can move them over to the telehealth bucket. So that was my experience. We used every avenue that we could think of to get our members seen. It wasn't just one particular way to do it.
Yeah, that makes a lot of sense. Really, really interesting. Especially going forward, I think having all those different capabilities will be really helpful in being successful. So, Andy, you're probably seeing me understand your business model real time here. So I love the idea of telehealth as PCP. And so I'm wondering, is there a type of member that's sort of ideally suited to be managed via a telehealth PCP, or is it really just any member?
That is a wonderful question, Mark. I in our experience, it's pretty close to any member. I do think that I think what we're going to see is some segmentation where. So I think the industry is going to move towards sort of tech-enabled continuous care or primary care offerings, replacing a lot of traditional primary care, and then having more traditional providers come onto platforms that companies like Firefly have built, because the technology it's built very differently. A traditional EMR is, as you know, built for kind of revenue capture and fee for service. So it's not really, the architecture of it isn't optimized for value-based care, to be honest, to enable, teams of people to care for populations in a high value way over time. So what companies like us have done is we've built technology that sits on top of the EMR, but becomes, that's where our providers are spending most of their time, not in the EMR. And then the technology layer we've built enables communication and coordination across teams of people and with patients and families, basically. And so, I think it's quite likely that that's where the industry is going to go. And then, Mark, I think I've seen this work for populations across the sort of complexity spectrum, or like, I think we all have concerns about for the really kind of psychosocially complex or vulnerable, are we leaving them out or sort of leaving them behind in this innovation? I actually see it differently. I think Laura referred to this in her comments. That population often struggles to come into a clinic for a visit and experiences all kinds of barriers when they interact with traditional providers, across a number of different dimensions. And so I do think kind of care delivery models will need to be more tailored for that population and not so much rely always on the patient being the one who's, attending a video visit in real time with their provider, as opposed to technology enabling a team of people, community health workers, nurses that come to the home, and sort of connecting with those folks and coordinating the care so that you can offer, an approach to care that actually, is effective for that population that works in their, unique circumstances. And so, yes, I think, you can probably tell I'm trying to move away from telehealth because I think that connotes video visits basically. And I think that's kind of taking a sick care system and putting a technology layer on top of it. I think where this needs to go is, segmented care for different populations that's enabled by technology to deliver, much better outcomes at much lower cost. And we're seeing a lot of evidence of that working in real time.
Fantastic. So as health plans and provider groups develop their sort of capability stack, it's really around making sure that their business model is more about population health and managing care versus fee for service, and having telehealth be just another avenue, another member engagement part that they have in their stack. Is that kind of how you're thinking about it?
I think about it a little differently. I actually think I think telehealth, the way you're using it, should become their stack. I actually think, sort of closer integration between payers and value-based primary care oriented providers will make more and more sense. And then that group really sort of curating a network and much more effectively navigating within that network in ways that kind of work well for different patient populations. And so, I think it's only going to work well for payers if they if they don't see kind of telehealth as like another vendor that's like kind of off to the side, and like if someone needs a video visit, they can do that person. I think they're going to need to understand a full stack approach and partner with the right technology enabled partners that are capable of sort of managing the whole risk or managing the full experience along with them.
Interesting. So that's a good segue into my next question, because I'm thinking, I hear in the news both sides, right? Like this is hopefully a one-off pandemic, and once we're all vaccinated and everything's fine, no more pandemic for a while, hopefully. Other people are saying maybe this is the way things go from now on. I don't know. But either way, let's assume that there's no more pandemic after this. What's the value? I'd love to hear from everyone here. What's the value of having this capability and switching this transformation to including telehealth and this new way of thinking about it? What's the value of that, assuming the pandemic's gone away?
Well, I think Andy brought up a really good point, and that is the cost of healthcare. So I think telehealth costs less, but a platform like Andy's allows us to provide better care, more personalized care, people that are going to be more engaged. And so ultimately, if you're thinking about population health management, we're going to have a healthier population with less cost. So that's my perspective on that.
Interesting. Yeah, I like that. Others?
Yeah, I also think that the particular the technology has given us opportunity for ease of access. I think access to care is still an issue. I think it's still costly to access care, not just from an out-of-pocket cost, but just time and effort, right? So this new technology, I think moving forward, has given us kind of quickly has kind of taught us about maybe this is an opportunity where we can reduce some of these barriers for access to care. At the same time, it's inserted a potentially a new kind of barrier, which is around a communication technology barrier, right? And I think that's where for us, I think is something we're really thinking about how we're going to address and solve. And maybe we've got a number of facilities that we call family resource centers throughout LA County. Maybe we can start staging those because they're in the community. We start staging some of those for some actual care visits, both in person, care as well as opportunities for video visits, and that kind of using those locations to kind of reduce the transportation costs and effort to get there. Also looking about kind of mobile kind of units to kind of solve some of these, not only delivery of the care itself as kind of these mobile clinics, but also kind of mobile potentially communication centers to help set up between their provider. And we just serve as kind of the conduit around for the technology to help solve some of these technology obstacles.
Fantastic. Yeah, I think that makes a lot of sense. I'm noticing this conversation has been fantastic and time has flown. I want to make sure we leave some questions or some time for questions. But any final thoughts from everyone? Anyone? Andy, do you want to just give us your wrap up there?
Yeah, the wrap up, just to kind of answer the last question, was, we know one thing for certain. We know that the pre-COVID traditional approach to care was structurally broken. That there were just like enormous waste and inequity of access and poor outcomes at ridiculous expense. And so my hope is, and this is, I think, true across society, not just in healthcare, that, part of, it's hard to say that there's any bright side in what we've all been through together, but that it does create the opportunity to move past some of the broken structures that were completely unsustainable. And as regards kind of healthcare and technology or telehealth, I think the opportunity is to actually begin to offer a service that has a rational or intelligent structure to it for 2021. And a lot of that moves past traditional barriers between primary care, specialty care, behavioral health, forcing the delivery of care to conform to visits, things like that. And then how do we use technology and intelligent design of care and incentives to remove friction for the past that actually makes sense for a given person. And so we're kind of working hard to figure that out. And, we're excited to partner with payers that are, there's just tremendous alignment, obviously, from the payer perspective, and starting to deliver, savings and reduce costs by, I think modestly 20%, but we're aiming for 50% at Firefly.
Fantastic. Yeah, that sounds wonderful. Laura, final thoughts?
I'm really excited to see what the future is going to bring, bringing technology together with healthcare. I think I agree with Andy. There's just a lot of opportunity. So, and as I move into my older years, I'm looking forward to utilizing some of that technology.
Great. Yeah. Mark, what about you? Final thoughts?
Yeah, I think the experience with COVID, and I think it as I said, I think exposed in stark detail about really around inequities in terms of access to care, and it really makes us think about that. I mean, for the mission for our plan is around trying to deliver care for kind of that underserved population in general. And we've always known that there's been inequities, but I think the COVID era kind of shown kind of in starker detail, contrast around what those inequities look like and what it could really mean. But at the same time, I think introduction and some comfort level and experience with some of the newer technologies, we begin to think about, I think it opens up the opportunities to think about a different model, a different way of delivering care, different modalities of delivering care. Both in terms of making it easier for access as well as from a cost standpoint. I just think we kind of were forced into that experience, and I think people's eyes, and particularly, I think a lot of decision makers have begun to kind of realize that maybe there is a better way if we really kind of think about it, because we've seen some of it work pretty well.
Fantastic. Yep, totally agree. I'd like to thank each of the panelists today. We've had a fantastic discussion and really appreciate your time. So go ahead, if you have any questions, go ahead and submit those in the comments and we'll go ahead and answer those. Have a wonderful day all.